So we're going to have a physician, not an expert in CGD, tells the parents of a newly diagnosed baby or very young child with CGD, the child is at high risk of early death. In other words, he read that first paper that Dr. Lighting, although she told me one of her little young patients calls her Dr. Lightning. I love it. I think that's my new. She is lightning, so it's great. So is that true, false, or more complicated? And I'll just show you a slide. It's false, but also more complicated. With current management these days, almost all children reach adulthood, but thereafter mortality does rise for high-risk patients, although we're doing better there as well, and patients whose neutrophils make less oxidants are at some higher risk. So most low-risk patients can expect to live past 50 and older, and we have some low-risk patients now in their 60s and at least 2/3 of patients, and I think we'll do better than that, can expect to live past 50. And this is without interventions that we're now, coming along with, like transplant and gene therapy and whatever. However, just living is not enough. People want to be well, and we do know that as patients get older, they get some of the inflammatory complications of CGD that you'll hear about, and so that too may influence moving along faster with some of the potentially curative therapies. So now let's go to the next one. A parent of an 8-year-old child with CGD who had a pneumonia at age 2 that led to the diagnosis of CGD has been on prophylaxis. You heard about prophylaxis, and many of you know it, and those of you who are patients here are taking it. And has not had another infection or any other problems for 6 years. And so I've more than once had the question asked, do you think my child's outgrown his CGD and maybe does not need all this stuff and should, we just move on with our lives? That true, false, or more complicated? So that's false. It's an inherited disorder, does not go away, nor does a child outgrow the problem. However, diligent administration and prophylaxis care to avoid exposures to mold and things like that reduces the risk. And the parent should be praised for excellent care of their child, or if it's an adult, you're doing great. However, luck also matters in that even with the best care, the average rate of severe infections remains about 1 severe infection every 4 years. Remember, that's an average. So it means that it means that some patients may go through periods where they have 1 infection, and another one, they'll have a year where they have 3 infections, bad ones. And then they can go for 7, 8, 9 years without a problem. So it's not unusual for that to be. And so, many of it isn't even just patients or families, but even physicians who don't understand the disease don't realize that their patient who's done fine for 7 or 8 years is still at risk and still needs to be seen when they have a problem and worked up and so on. And in some cases, it's up to you as patients or parents to nudge your physicians to do the right thing. The parent of a 15-year-old with CGD asked, since my child's been on daily Bactrium for 13 years, do you think he's become resistant? You hear about antibiotic resistant, or maybe the body adapts or whatever. Is this true, false, or more complicated? So this is also false. The protective effect of Bactrium receptor does not decrease over time. It's one of the few antibiotics that has less effect on the body's normal bacterial ecology. You hear about, we now realize that the ecology, and Dr. Zerbe will probably talk a bit about the ecology of the organisms in the gut, and maintaining that normal ecology is important. What's also important is people don't understand that CGD is one of those diseases where you generally don't get an infection from things you're carrying around all the time. Most of the bad bugs are out there, not in your body. And so, this puts up a little bit of a fence. Bacteria can jump over that fence, but it puts up a little bit of a fence. And so the bacteria out there aren't becoming resistant. Now when farmers use bacteria to help their chickens or pigs or cattle grow, that creates troubles. This is not the same kind of thing, because there it's the bacteria that are in the animals and so on, and doesn't relate to CGD, but just people confuse the issues of antibiotic resistance and so on. So CGD patients are told to be careful not to do things that expose them to high concentrations of fungal spores. Should not swim in some natural bodies of water because of exposure to bacterial pathogens. Does this mean they should avoid all outdoor activities? I misspelled activities. It's okay. And so I've had parents of young children who as they transition from pretty much being indoors and now they're going to go to school and so on, and say, can I let them do the things that other kids do? And the answer to that is probably more complicated. Most outdoor environments, interestingly, even a walk in the woods, has lower exposure to mold spores than your cleanest room in your house. And so don't worry about taking a hike in the woods, but don't stop to dig up the toadstools. So spreading mulch, digging in the earth for fences or gardening, repotting plants, cleaning a damp cellar or garage, mowing the lawn. We had an unfortunate situation of a child in his teens who, most of you can't get your teens to do anything. But since he was told you can't do this, he wanted to mow the lawn, and he cleaned his lawnmower and actually got quite sick. So you want to, they do get a pass. So have them do something else. They can clean the dishes, but don't mow the lawn. Shouldn't take a hayride. It's hard to describe what you do or don't do. What you want to think about is if it's something where it rains on it and then dries, or it's your cellar that gets damp and then dries, mold grows there. Those are bad places to do things. You may play sports such as, we asked about baseball, soccer, running around the field. You can do all of that. We don't like to see people swim in ponds or brackish water. Some lakes may be a risk for swimming. It's hard to know. So we're sort of, because we can't tell you that lake is okay, we tend to say, don't swim in the lake. Interestingly, swimming in a clean ocean is good. Now, obviously, if you read in the newspaper that there was a sewage leak down the road, then the ocean's not so good either. And certainly you can join the swim team and swim in a well-chlorinated pool. So, patient with CGD with a fungal infection is started on oral voriconazole or posaconazole, told to avoid sun exposure, particularly with the voriconazole. They hate wearing hats. Not even you as patients, but think of your parents asking a child to wear a hat. Ain't going to happen, but it's important. Long sleeves, hot weather, and so on. And so, is this protective? True, false, or more complicated? And that's false. Sunscreens only protect from ultraviolet light. So your SPF 1000 isn't going to help you with that. Voriconazole is a really bad actor, and people have actually gotten some skin cancers, when they've had really bad burns from the voriconazole. Lesser extent with posaconazole, and interestingly, it doesn't seem like itraconazole really sensitizes people that much, and we haven't seen much skin sensitization. But if you do need to be on Vori, lesser extent on Posa, you want to wear hats, you want to wear long sleeves. I know, using sun umbrellas sounds uncool. Zinc-based stuff and full sunblock. So there's that. CGD is a type of inherited immune deficiency. Some doctors not familiar with what is the defect in immunity may tell a patient not to receive some kinds of immunizations. I hear that all the time. So they confuse the SCIDs and some of the other lymphocyte abnormalities where not only do they not respond to immunization, but it may be dangerous to get a live vaccine. Not true with CGD. So this is false. CGD patients should receive all standard killed and live vaccines required in the U.S. CGD patients make protective antibodies, and none of the standard U.S. vaccines are a risk to CGD. However, it's more complicated in other countries. So many countries, when a child is born, within the first weeks of life, they administer something called BCG, which is a kind of weakened tuberculosis vaccine. It's a live vaccine. And CGD patients, like SCID patients and so on, can get very sick with BCG. It can be deadly. But it is important. So as with all things, things are always a little more complicated. So this is the last question. A 20-year-old patient with CGD asks, my friend with CGD, I know from the clinic, just got a tattoo and an ear pierced, and I'd like to do that. He seems to have done fine. I'd like my own tattoo and ear piercing, and I'm assuming it's okay. So no clear answer to this question. No physician feels comfortable encouraging even a healthy person to go out and getting a tattoo or an ear piercing. But but on the other hand, I don't want to say don't ask your physician things. You do want to ask, but it's kind of a loaded question. But what's interesting is, if you're going to do it at a reputable establishment. In the case of piercings, keep it clean, apply topical antibiotics. So, experience is everything. Many of our CGD patients have gotten tattoos without complications. Rarely a patient with CGD has gotten a severe staph infection from a piercing, and so you're forewarned. In theory, some CGD patients could have excessive scarring, keloids from tattoos or piercings, but I actually haven't seen any patients with it, but it doesn't mean it couldn't happen. And I'll stop there, and if we have time later on, you can ask about Mythbuster things too. So.
Yeah, we're actually doing really well on time, so I think we're going to go to the next presentation, and then we can do some questions right before we break for lunch.
So you can ask us all about the myths later on. Thank you.